Hi, yes, my name is Olazagasti. I am an assistant professor of clinical oncology. I do thoracic oncology and head and neck at the University of Miami, and I'm so excited to be here at World Lung and here with my colleague and friend, Dr. Rodriguez.
And Dr. Estelamari Rodriguez, I'm clinical research lead of the thoracic group at the Sylvester Cancer Center, University of Miami.
And I think it's something that I wanted to do this with you because this is when we met.
Yeah.
Back in 2019, it was like right there in Barcelona. It was my first time coming to Barcelona to World Long. I was a fellow in training. I was a little bit overwhelmed. I really didn't know what my career was gonna look like. And I remember meeting you. You were about to start the University of Miami, and now look at where we are. Like you've taught me so much. We've been able to collaborate, and you've helped me and mentored through my career. So it's just kind of like a full circle.
No, it's wonderful. So we both come from a small island, Puerto Rico, with a lot of people. So we had to come all the way to Barcelona to meet 6 years ago. But it's been great to see your career rise and really find each other, because finding support is what it's all about, so that our careers and people do better.
And I always say, and I've said it before, like it's important for me to like find my tribe as a Latina physician. When I was sometimes in training, I really didn't know what I wanted to do. I didn't really find people that were doing the thing that I was passionate about. And so I think coming to these meetings and finding people that really have passions similar to yours is something that I always look forward to, that I always tell now my mentees. And so what's some of the things that you look forward to when we come to like World Long?
Yeah, so I mean, I actually love going to the poster session, because you kind of get ideas of what people are thinking about, ideas that you had that you can look in your specific population. I think collaborations and coming to these meetings often, you make friendships with people all over the world. And now, like all these people I have met in social media, I can see them for the first time. They feel like they're longtime friends, and we never met in person. So it's a really great place to be. And it's special because it's only thoracic oncology. So you see people, pulmonologists, surgeons, people who are all working in the same goal, which is to find cures for lung cancer, which is amazing.
Absolutely. I think obviously the size is important, but the size is always something that you can always like refresh and do it and see about it back home. But you don't get to experience your colleagues and your friends like in settings like this. So meeting people, connecting with people, and like you said, like I go back home and I go around and I get so inspired by one project I want to do next that I'm writing in my notes. Okay, like I got this idea from this and that. So it's just about like creativity and really like growing and learning from each other, which is the part that I love the most.
And I think the other really amazing thing that this conference is integrate patients and patient advocates. So we have, I think in lung cancer, we've been really blessed with patients who are now survivors and have benefited from this treatment. And they're really opening our eyes to what is the experience of a patient that gets targeted therapy, that gets some of our new immunotherapies and antibody drug conjugates. Like we can write these trials and look at P significance and curves, but you really have to talk to patients to see how they experience this. So one of the work that we presented here from the University of Miami is looking at the real world data of patients receiving tarlatamab, which is an antibody drug conjugate, a bispecific antibody that is using small cell and is really revolutionizing treatment for patients that we had no options after chemo and immunotherapy. And we found in our subset of patients in South Florida with a lot of elderly patients is that that treatment can be very toxic, and you have to do a lot of patient selection for treatments like that. We saw a very high degree of patients that have had cytokine release syndrome. We saw a high amount of patients that had side effects and early deaths on treatment. So really a lot of caution about treatments. When you bring this data into the real world, you have to kind of think of your patients in front of you. For us, it's an elderly population.
Yeah, and I think it's important, like when you see these trials, that you don't only take into consideration the numbers, but to study how that impacts in real world, like what did stress plays into real world and patient-reported outcomes, because like it's not always the same, and then really you need to know understand your community. Everyone kind of like has different toxicities and tolerability, so it's important to understand your patient population, like you said. So that's amazing. And another study that we did that I am like, actually doing as part of like my K-12 and my program is that that I'm very passionate about screening and early detection. And so I'm doing lung cancer screening in head and neck cancer survivors. But I wanted to understand from the patients that do not meet eligibility criteria for screening, because this is like Hispanic populations. Are they meeting other screening eligibility criteria? So I try to incorporate the PLCO, which incorporates a little bit more of risk factors like education, family history, beyond tobacco exposure. And I found, so the PLCO, they merged race and ethnicity into one category. And so a lot of Hispanics self-identify Hispanic, but when you ask them their race, they're like, "Oh, I'm white," even though, like, we're not. But there's no way to write like Puerto Rican or whatnot. And so when patients they self-identify, when we do the score using the white race, the scores were high and they meet eligibility. Versus when we use Hispanic as the race ethnic component, more than double are like not eligible for screening. And so even though this criteria has been known to include more at-risk people from minority populations like African Americans, but then maybe this doesn't translate into Hispanics. And so I think it's important to really understand each population individually. It's not a one size fits all approach, to really look for what works for our patients.
Yeah, and we have to kind of fix the data because the National Lung Cancer Screening Trial that is now a decade old or more, that trial had 1.4% Hispanics. So it really didn't talk about what you're finding in your data. So it's really critical. The other plenary session abstract that was presented today that really stayed with me was from Manchester, UK, looking at really raising the age limit for lung cancer screening, going from 74 to 80. And it was a really interesting discussion about how age is just not a number, like how really patients who are elderly have a high pickup rate of lung cancer, detection rate of lung cancer screening. But there was a lot of discussion about even if you find lung cancer, can patients tolerate surgery and gain benefits? So a lot of know that we have to do to really get patients fit as they get older so they can benefit from screening and surgery.
Yeah. So many exciting things. I think we can talk about this like, for the longest time, but it's just like so much more data to see. I'm excited to be participating in a session later today, and so we'll stay tuned.